So just to start off, if you would introduce yourself and tell us where you work.
Yeah, I'm Funmi Olopade. I work at the University of Chicago.
Okay, so will you briefly describe your research focus?
Yeah, so I'm a practicing medical oncologist. I just returned from clinic, but what motivates me is to get a better understanding of why any person develops breast cancer. And so by asking the question about the etiology of breast cancer in my patients, I've really been focused on how to use my understanding of the genetic alterations to improve outcomes for breast cancer patients. And so my work is being grounded in every patient who comes into my clinic asking, why did they get breast cancer? And that's what led us to really understanding inherited forms of breast cancer, being able to collaborate with scientists all over the world to find BRCA1, BRCA2, and other genes that predispose to breast cancer. And once we found genes that predispose to breast and ovarian cancer, I'm motivated by trying to find every high-risk woman so that we can help them beat premature deaths from breast or ovarian cancer.
Okay. So what was your reaction when you learned you would be getting the Jill Rose Award?
I was really very surprised because, BCRF started funding me a long time ago. And I gave them the idea that I really want to add to the contributions that Mary Claire King had made when she discovered that breast and ovarian cancers were linked to BRCA1 gene. And then other members of our scientific community contributed to finding BRCA2. And then we spent, another decade looking for BRCA3, but we didn't find it, but we found other genes. And then BCRF will gather us together. And I remember vividly the meeting where I started talking to Mary Claire King about, maybe we should just do a lot of this work together and go and sequence, genes of women from Nigeria. Because, anytime we talk about aggressive forms of breast cancer, or we talk about breast cancer impacting young women, I ask, why young women? Why older women? And if the face of breast cancer had always been about older women, I really wanted to double down to younger women. So the work I do in Nigeria, these young women, they are under 50. They're not getting screened. And we don't know why they get breast cancer under 50. And that's why I really want to say a big thank you to BCRF for funding the big idea. And of course, we got more other people to fund us, but it was really at the BCRF event that we thought about this big project. And then I find that it's not about, your ethnicity, your race, your gender. It's really about what's predisposing you to get breast cancer at a young age. And then what can we do about it? So, every year when we go to the ceremonies, we hear about Jill Rose and her amazing family and what they really were doing to support breast cancer research. So getting the news that I was going to be a winner, I was like, oh, really? I was very happy because, that award is so prestigious in our field. You get to win an award with every prominent breast cancer researcher in the world having won it. And so I was very happy to be in the company of other people who had won the Jill Rose Award.
Okay, so I know you talked a little bit about this already, but what impact has BCRF had on your research? I know obviously it's been like 30 years that you've been a researcher. But just a couple of examples of, what the organization has allowed you to pursue.
Yeah, the reason why this award is actually so important, and so I'm so grateful for it, is because I've always really been interested in genetic justice. And I know that a lot of patients are not comfortable with genetics because of the idea that they might use genetics to discriminate, and genetics might be used to exclude people. So I've been very, very really conscious about the racial differences and the biases in the research that we do. And because I work on the south side of Chicago, I also know that it's not about black and white or brown. It's really about how can we help you when you face a diagnosis of breast cancer. And those kinds of research are not the first research that will be funded by the NCI. It's not sexy enough to say, I want to go and find out if Nigerian women have BRCA1 mutation. It's just not what you get funded for. Or I want to go and treat women in breast cancer in Nigeria with breast cancer because they have no access to treatment. And so when I first got notified that BCRF was going to fund me, the first study I wanted to do was I just wanted to go to Nigeria and treat women who were participating in my research. Because when we ask what happened to these women after they gave us their sample and we learned about them, it was always disheartening for my collaborators to say, oh, they died. Or the family members to say, well, you got our blood and our mother died and the doctor never wanted to talk to us again because they had no money and they did not have access to treatment. So my first grant was to go and actually see whether I can develop a clinical trials platform so that these women can have a chance to be part of a global network, really figuring out how to treat and cure breast cancer. So when we say a breast cancer is aggressive, it's because we don't know how to treat it, and then it ends up killing a woman prematurely. And so when a young woman develops breast cancer that they were not expecting to have, the question is, how do we screen that type of woman? How do we treat them when they get breast cancer? And the only way you can do that is by studying young women with breast cancer. So that's why the funding that BCRS had provided for me has been so amazing in helping us train people in Nigeria, teach them how to do clinical trials. And now the aggressive breast cancer that was not treatable is now suddenly treatable, and we're getting survivors. And it would never have been possible if I hadn't gotten the money from BCRF to do it.
That is fantastic to hear. I had read that you'd been interested in being a doctor at a young age because there were so few doctors and medical resources in Nigerian villages when you were growing up. Were there any options at all at that time when you were growing up there? What would a woman or could a woman do in your village if she found a lump in her breast?
I'm from Lagos. I went to school in Lagos. Lagos is a mega city. And the reason why this is actually a passion of mine is Africa is full of wonderful women who, like me, went to medical school, and now they're in a country where there's not the resources or the infrastructure to treat breast cancer. And it's because the global community actually didn't think that women in Africa develop breast cancer, because people were not aware that these are sophisticated women. In fact, I tease my friends that women in Nigeria use more makeup than women in New York, right? And it's because women in Nigeria, in Lagos, they're fashionable, they love music, they love fashion, and they are all about beauty. And so when they hear that they have breast cancer and people don't tell them how to get their breast cancer treated so they can remain fabulous, that's why some of them decide, okay, I'm not going to do this. And so every time I talk about my work and I talk about Africa, the image that everybody has is, oh, this poor woman, they're dealing with so many other things. They don't need to worry about breast cancer. But every day, my classmates call me, another friend has breast cancer. My relatives call me, another person has breast cancer. So how are they going to get treated? Well, I want them to be treated like everyone else in the world. I want them to be treated like I will be treated in Chicago. I want Black women in my community in Chicago to be treated like everyone else. And that's what they all tell me when we ask them. And so, however, if we have policies that doesn't allow pharma and pharmaceutical companies to go and do clinical trials everywhere, and we all tolerate it, then of course these women continue to get excluded from the global community. So that's why when I come to BCRF, I talk about inclusive excellence, right? They're amazing women that were in my classmates, that were my classmates in medical school. Women have been empowered and in the workforce for generations that I know in Lagos. And the fact that we don't have established cancer programs in Lagos is the reason why I'm particularly honored to be able to use this platform to say, go to Lagos and see the women who need breast cancer treatment. And then you will know what we need to do as a global community, really wanting to eradicate breast cancer as a cause of death. Lagos is a mega city of 17 million people. And whenever I go anywhere in the world, I go to Brazil, I go to South Africa, I go to East Africa, and I see beautiful Black women all over the world. I'm asking, these women are at risk of breast cancer just like anybody in America. So what am I going to do about it? And that's why I'm so happy that I have the Jill Rose Award and I have this platform to mobilize solidarity for us women to be together and to find solutions. So that's what I'm grateful for. And that's what the BCRF has funded or allowed me to do.
Okay, great. I know even when you first came to Chicago, there were some predominantly African-American neighborhoods that were basically medical deserts. What challenges did you observe there? And how did that experience fuel your interest in investigating breast cancer disparities?
Yeah. So, so New York is my ultimate favorite place to be. But my first entry to the US was actually, I came to visit a relative who was living in Harlem. And, Harlem Hospital, we have great surgeon that really described disparities between Harlem Hospital and Memorial Sloan Kettering, right? I mean, it's the same city, and you can see the disparity in every big city, right? So when I landed in Chicago, I landed at the Cook County Hospital, which is the predominant, public hospital. It's like Bellevue in New York, right? So if you go to these really amazing cities, you see immigrants, predominantly immigrants in these hospitals that serve, they may not even be poor, they're working poor, right? They're working hard, they're hustling, they are policemen, they're, working in the fire department, they're middle class, and yet they don't get to participate in our clinical trials because we take our clinical trials to the fanciest hospitals. So to me, it was always about, why do we have two Americas? where some people have more than they need and some people just don't have any, right? Whether you go to San Francisco General in San Francisco, where my very good friend Laura Esserman works, that's why we became really very good friends to say, why is this happening? We've got to move our clinical trial. So I'm working with Laura on the wisdom study, and we want to recruit 100,000 women to know their risk of breast cancer and to screen based on the measures of risk. And when Laura started her work in California, she had 48 Black women participating. And I would say, Laura, why are you staying in California to look for Black women? Come to me in Chicago. They're going to do it. They're going to participate because I'm one of them. And when I tell them, let's do this, they do it. And now we have, almost 3,000 women in Chicago participating. 25% of them are Black because they want to be part of a solution. They're Black and brown. So that's what I mean by inclusive excellence, right? We all come from somewhere, but we can do this work in solidarity.
All right. So what would you say is the most fulfilling part of your work? You probably covered this a little bit already, but it's just a really interesting.
Yeah, well, I think the most fulfilling, I teach in an academic medical center, and the most fulfilling part of my work is really being able to impact knowledge into the next generation. And so this is the beginning of the year. We have new fellows, they're coming into the clinic, and I'm seeing patients who have been in my clinic since their mother was dying of ovarian cancer. And they came and we found out that they have a BRCA1 or a BRCA2 mutation. And we have the idea that, okay, just come in and get screened. And now the woman who's been screening with in our MRI study, she's now 65. And I'm thinking, okay, what should I be doing with her now? And it's like, Dr. Olopade, I don't want to leave your clinic. What's the next thing I should participate in? And now we're talking about, well, maybe we can do screening for pancreatic cancer. Because now as people are living longer, they're not dying, they've not had any cancer, they just want to be followed. And I'm reassuring her that, yes, what we knew in 2012 no longer holds, because now this is 2023. We have drugs that can treat BRCA-associated breast cancer. We have biomarkers in the blood that can detect these cancers early. And you know what? We have faster magnets that if you do MRI, we can pick up the cancer in the earlier stages. But what's been rewarding is that these women are not even getting any cancers, right? And yet when they came to me, it was like somebody said, predictably, you're going to get breast cancer. And now, because we've optimized their prevention, they're saying, okay, Dr. Olopade, what else is in your pocket, right? So that's the most rewarding part of my journey, because we have a registry, we have these women coming, and we keep moving the needle, and the research keeps going forward. So it's really been gratifying to have had a movement to support women who are at high risk, to find new ways to treat and prevent breast cancer. And now we're in the frontier where men now want to do what we did 20 years ago. And we're talking about men's health, talking about the fact that men can also have BRCA mutation, and they need to have these conversations with their daughters, because we're in this together.
Great. All right. So I just see from your bio on our website that your latest project is to begin genetic testing and counseling for breast cancer patients and their families in Cameroon. Can you tell me a little bit more about that? What you hope to learn?
Well, so it's not just in Cameroon. In fact, the fellow who just left my office came to me from Rwanda. And it was because, depending on who colonized your country, you are either going to be speaking French, or you're going to be speaking English, or in some instances, you're going to be speaking Portuguese. Of course, we also know that in some Latin American countries, it's Spain. So you have Spanish. So as we talk about the diversity and we talk about Black and brown, when I ask people in my country, where do you come from? And it's like, oh yeah, we came from Spain and it's northern Spain, or it's Ireland, or it is somewhere exotic. And I was like, is it Greece? Or is it? So we all came from somewhere, and then we are here as immigrants, and it's either we're European ancestry or African ancestry. And African ancestry actually is all of us, because we are all one human race. So as we translate our work from one country to the other, right? The other person who was in my clinic is from Asia, because they also want to do genetic testing in Asia. And then we're asking, what language should we communicate? How do we communicate risk? Do they do their own what we call indigenous language, native dialect? Do we convert all of it into French or English? How do we actually tell people that they have BRCA1 gene mutation, right? So when we did our work in Nigeria, we had to translate into the local language, which is Yoruba. We have to do graphics, which has a Yoruba woman wearing the Yoruba outfit so that the patient can connect to the image we're giving them. So what we have done is to then train our nurses who have trained Nigerians to train the nurses in Cameroon, translate all of our stuff into French and the local language. And now we're going to translate it into French that Rwandans can speak, or they can translate it into their own local language, so that the women, even if they don't speak English, they are not illiterate. They are literate in their own language. And we just have not communicated with them in the language that they understand. And so that's what's exciting about this work, is that we're going to be able to not only just say, okay, we have done the testing, but we're going to be able to treat women effectively, and we're going to be able to give them the opportunity to have genetic testing as standard of care, so that they can now be able to talk to their daughters and the next generation about how to prevent breast cancer and how to prevent themselves from dying from ovarian cancer that is preventable.
Why is research so important to move the field forward?
Oh, I mean, the research is the only thing we can do to move the field forward. I often talk to my genetic counselors and fellows that as doctors, we overestimate our own importance. And that's a lesson I learned from the pandemic, because we were predicting, we were doing modeling. And given what happened during the pandemic, we as physicians have to be a little bit more humble about what we know and what we don't know. And there are two things that I do that I absolutely love. Vaccines prevent cancer. And I grew up just putting my hands out, getting lots of jabs, because we know that the smallpox, the chickenpox, the polio, all of those really dreadful childhood diseases, we overcame them because we were able to vaccinate children. And it seems as if we have forgotten all of that. We have HPV, we have vaccine that will basically eliminate HPV as a cause of cervical cancer, head and neck cancer, and yet people are not getting the vaccines that they need, right? How can we prioritize that? And then breast cancer, I'm telling them about genetics, and I'm saying, okay, you have this high risk of getting cancer. And now they are like, okay, now I'm 65, I haven't had cancer. So what's this prediction that you're talking about, right? And I have to say, well, we act based on what we know now, but we're going to have better ability to predict the future. And this is why I'm excited about artificial intelligence. One of the new collaborations that I'm developing with our colleagues through BCRF is that artificial intelligence is actually going to propel us further, right? I'm going to be able to not only talk about the genes I'm going to talk about what are you eating that's increasing your risk. How about your weight? How about your blood pressure? How about diabetes? And we never used to think about all those things that make a human being. How much alcohol is bad for you or how much alcohol is good for you, right? Alcohol is the #1 risk factor for breast cancer. How many women know that and are acting on it? They know it only after they develop breast cancer. And I think we need to do better. So I'm really looking forward to moving prevention forward, being able to be an advocate to say, let's pull all of it together and do risk prediction so women can at least be empowered to prevent breast cancer or diagnose it early when it's most treatable. So as a geneticist who believes in vaccine, I have a tall order job, right? In convincing everyone that this is good for you. You need to know your risk, and then you need to do something to lower your risk.
Okay, great. And that the AI study you mentioned, is that something BCRF funds or?
Yes, so at the last meeting, this is the beauty of having data. So I've been collecting data on every one of our patients because BCRF gives us money unconditionally, right? And then you can use it to do really interesting stuff. So if a woman gets a mammogram, right, you can now predict from their first mammogram when or if they're going to get breast cancer 5 years later. And I was able to really think about funding a postdoc, a young man from Nigeria who came to me and was really interested. And now we can actually use a first mammogram or an MRI to predict future risk. And if we can use that and integrate that into how we do our work, it wouldn't matter where you live in the world. It would just be important that we get your digital image. And with that image, we can predict your response to treatment. And so my good friend, Chuck Peru and we met at a meeting a long time ago. We meet every year at BCRF and we think about new ideas and new work that we want to do together. So this is our latest one that we're doing, and we're excited to work collaboratively to really move the needle to use risk of aggressive breast cancer and then divide women before they ever get cancer into who's at risk of aggressive breast cancer and who's not. And then we can do risk stratified screening. So I'm really excited about what BCRF has done to bring the Breast Cancer Translational Research Consortium together. I'm excited to have met wonderful friends every time I go to New York. And then we plot new ideas and new ways that we want to do our work. So without BCRF, I would never have been able to realize, the imagination, because I'm always thinking about what can I do to get better personally, and what can I do to get better outcomes for my patients.
Great, thank you so much. Is there anything else you'd like to add, or otherwise I won't take up any more of your time?
Yeah, no, just really to thank all of the funders who support BCRF. And it's not enough to give us money to go and do our research. It's even more marvelous when we can all land in New York and interact and begin new collaborations. So yeah, Chuck and I and Dr. Khan, we began a new collaboration last year, and I can't wait to see what we will be able to do 5 years from now.